Okay. Hi, everybody. Like I said, I'm Joshua Wood. I'm a therapist and operations case manager here at Northwood Health Systems. A while back, we had the idea of implementing a QI project back in, I believe it was, January of or July of 2021. And before then, we had noticed a pretty low percentage of people following through with actual outpatient MAT appointments after discharge from crisis stabilization unit services, as well as outpatient ambulatory inductions. So for our executive sponsor, we chose Jeremy Sagan. He is the director of operations here at Northwood Health Systems. The change leader is myself. The change team it's consisted of Tina Harper, who is the department head of substance abuse down here, Joel Baker, PR, and Dr. Stephen Corder. The project area, it surrounds office-based medication-assisted treatment programming. It's in the substance abuse department, which Tina is the head of. The primary objectives of this program, it was kind of one of those things that just kind of happened. I think I mentioned this a while ago. It was back when I was still in school, and Jeremy had been talking to me about retention and how we can improve our efforts. So one night I just happened to get done with an assignment sooner than I anticipated, and I still was kind of in that mode. So I just kind of went ahead and created something. The objectives of our what I like to call project retention, improved attendance of the MAT representative or change leader in upcoming discharge planning meetings regarding MAT clients, tracking the titration of MAT clients and meeting with them during day 2 or day 3 of titration. That's also contingent upon their regulation on the medication as well. Establish communication between CSU technicians, CSU nursing staff, and rounding nurses, and having them include the change leader onto the actual nursing report, which is sent out twice daily to check the status on any potential MAT client, if they're coming close to discharge or what have you, if there's any issues that need to be addressed and things of that nature. So the idea was to have, our providers, before we ever even begin considering prescribing them the medication, providers have to meet with them face to face in order to get the ball rolling in that regard. So I thought it would be a good idea to have the change leader also have a face to face with the client or clients that are coming off the discharge, for a multitude of reasons. One, it kind of puts a face to the name, which is the MAT program. Because when you're on the crisis stabilization unit, you don't really see much of us because, between Tina and myself and the rest of the change team, our schedules are very, very packed. So we don't have a lot of time to see a lot of people. So in that regard, we were able to iron out a little bit of time with these notifications from the crisis stabilization unit to allow ourselves to go up and meet with these clients. So having a face-to-face with these clients ultimately results, in theory, they would be meeting with the change leader or another proxy from the change team for a face-to-face meeting before discharge to go over any questions or concerns that they may have. Usually what I'd like to do or what we do is we would give them somewhat of a tour of where they'd be going after their after their CSU stay. So giving them a pretty much like a warm handoff. I think Tony mentioned this earlier on in week 1 or week 2 of this didactic, a warm handoff to us down here just to kind of show them the landscape, the lay of the land, where to go, who to talk to, what to do, and just kind of give them essentially an idea of what to expect after their release from inpatient treatment. So then we move on to the project status. This is ongoing. We implemented it in July of 2021, and the data pool was collected up until January 31st of 2022. January 2021 to June 2021, there is a 67.89% a percentage of clients that went to their first MAT appointment, outpatient wise, ambulatory, after discharge from crisis stabilization services or after outpatient induction. After the project was implemented on July 1st of 2021, we see a marked increase of 89.12% of clients coming to their first MAT appointment after CSU discharge and or outpatient inductions. So it has absolutely been something that it's been very, very good regarding client retention, follow through with continuity of care, et cetera. So the application part of it, we essentially what we did, they included the delegated representative is in attendance of discharge planning meetings, giving clients tours of the departments, including but not limited to therapists, lab core where we provide the UDSs, and the group rooms to establish some familiarity and rapport within the department. Nursing staff includes the change leader on daily and nightly shift reports to allow for the tracking of MAT titrations. Then to assure the establishment of contact, myself or a proxy will meet with a client during day 2 or 3 of titration, depending on where they're at with the regulation of the medication. Rather than meeting on day 1 when the individual will not likely be regulated on the medication, it would be more appropriate to meet with them when they're closer to establishing more of a maintenance dose and also mental and physical equilibrium regarding titration onto Suboxone. This also allows the representative to meet with the client before an unexpected or unanticipated discharge to kind of safeguard and maximize efforts for retention. Also, furthermore, marketing on unit or on the CSU with user-friendly advertisements and or reminders to speak with MAT representatives before leaving the building for discharge. Lastly, providing a client with a business card or a flyer is what we came up with to take with them upon discharge, which includes the IOP schedule, MAT schedule, and various extensions of those within the MAT and substance abuse department. And that is a document that I included. I think I sent that on with the PDF to you, Jay. So in that regard, we have seen an exponential increase in not only retention, but also growth in the program. I know one question that I have personally is how can we do this better? What can we do better regarding client retention, continuity of care? What are some things we may have missed, and how can we further benefit from implementing more strategies and things of that nature to help with the QI initiative? And Tina, I think this is a good one for you to ask, is like, what about contingency management? Has that been something you all have discussed, considered, or potentially utilized? And that is, in essence, the presentation is.
Thanks, Josh. That was great. Appreciate it. Now, typically what happens when we do echo is we ask for clarifying questions. So does anybody from the group have any kind of clarifying questions on anything that Josh has presented before we go into further discussions? Just feel free to unmute and go for it. Okay. Good job, Josh. No clarifying questions. So we will open it now for basically general discussion and back and forth. Who would like us to start? You can see some of the questions they had on the form there. I'll leave it up for a little bit longer just so everybody can see everything, and then I'll take it down so we can see each other. But you can see that they're looking for essentially next steps. What can they do? They've done something well, but what's next?
Without sort of getting to those questions, can I just first say, first of all, Joshua, thanks so much for a great presentation, and congratulations on your already such positive numbers in a 6-month time span. That is just so cool. So congrats on this great project.
Oh, thanks very much. That's
a couple things. Yeah, a couple things that I loved. was a really thoughtful decision when you were talking about, you guys sort of made the decision to meet them on day 2 or 3. Makes a lot of sense why to not meet them on day 1, because they just may not be emotionally present to hear what you have to say. And I also really liked your thinking of, if we wait till discharge date, well, then we run the risk of, maybe they end up leaving a day early, or maybe our schedule gets busy and we're not able to meet them. So I really like the kind of thoughtful reasoning behind that. And I also really liked your, it's where we're going at with our QI project is how can we, in order to increase retention, how can we increase engagement to help with that? And so the idea of having that face-to-face exchange with them, to me, that's engagement, and probably makes a lot of sense why you've had such a positive jump in your numbers.
Thank you, Katie.
Yeah, thank you. Those are my sort of initial comments.
This is a 100% a team effort. This is by no means just me doing all of this, by the way. This is like, I could not do this without the people that I have on my team. This is just something I came up with, and the team is helping me implement it. So I don't want to take all credit here. But a lot of this credit goes to Tina Harper herself, myself, and the rest of the change team as well. I just wanted to clarify that this wasn't just a me thing here. That's all.
Josh, it's Tony. Again, reiterating what Katie has said, is fabulous results. When you started at your baseline, did you make a projection of how much for this particular population that your goal was to increase from 67.89 to what did you envision? Like what was defined as successful in your head or your plan?
Yeah, Jeremy Sagan and I were talking, and he made it very clear that when I pick a number, I need to stick to that number. So he wanted me to play it safe. So of course, me being, just optimistic, I was like, let's shoot for, 85%. He was like, why don't we bring that on down to about 80%? And I was like, oh, that seems feasible in a 6-month period. So yeah, we were trying to get into the 80th percentile, which we did successfully. I think we hit the 80th percentile within the first 3 or 4 months, if that. And then it's continued to grow thereafter. But as we all know, with MAT and things of that nature, there's always people coming and people going, and there's always an influx and things of that nature. So we kind of just roll with it. We roll with the resistance, but ultimately the numbers as of January 31st, 2022, putting us right on the edge of the 90th percentile, which is far more than I expected us to reach. So yeah, it was right around the 80th percentile, Tony.
Great. So you've exceeded your planned goal, what you would define as successful. You actually well exceeded it if you set it at 80, and it's almost 90. That's fabulous. So the 2 questions I have as a follow-up is, do you think at this point, investment and more implementation interventions for this population, when you've almost hit 90% to first visit, is it worth the effort to basically, you only have 10 percentage points to go up? And number 1, so would you want to continue with this particular population, CSU discharge to first appointment? And then the second question is, the interventions that you put in place to be successful as you are they, what impact did they have on like employee satisfaction or, any issues with continued process, this continued process, any negative secondary feedback, anybody complaining like, oh, this is really, I don't have the time to do this forever, maybe going up and seeing these people, or is this something that the team feels that they can integrate in their schedule for ad infinitum, and it's just going to be part of your process?
Oh yeah, both very good questions. To answer the first question, we've also it's also kind of organically grown into outpatient ambulatory inductions, without a big portion of what we would do for CSU induction. So if we have somebody being inducted on an outpatient basis, we like to meet with them before they leave the clinic that day. And even at 89%, like I still, and we still as a team, we'd like to see that at, 95%, 96%. Like there's really there's no ceiling there that we really want to like stop at. We want to continue going, continue growing as much as we can. To answer your second question, in the beginning, yes, there is a little bit of kickback because we had to include other members of different departments to help us out with our QI initiative, and they weren't really seeing any benefit from it, because they were kind of just passing along the data, they were passing along the messages. So yeah, it could have been a little bit of a hassle for them in the beginning, but I mean, it really wasn't very much of an ask. It was more of just like communication, just communicate effectively within not just the change team here, but it really helps bridge the gap when we have communication from our nurse practitioners, our other providers, our CSU nurses, our just everybody in not just the substance abuse department, but just in the agency in general. Having that communication has been very, very helpful. Was it difficult at first to get everybody on board? Absolutely, because it was a change, and that's not something everybody likes to do whenever everybody else has a million other things to do on any given day. So, but whenever they started doing it, we tried to make it to a point where it wasn't going to cause anybody much of an extra headache, if you put it that way. So what we kind of came to was just add the change leader to the nursing report. We'll then kind of take it upon ourselves to, track their days, their titrations. And then we have another nurse, supervisor of nursing upstairs, who sends out reports that are pretty comprehensive. I think Tina would agree with that, regarding our MAT clients. And if there's any issues with them, like he typically sends us, as our whole team, something about them. So I guess the main barrier in the beginning was communication, but since then it's become a lot more seamless.
And I'll just kind of jump in to address, are we planning to continue this? Yes, we're absolutely planning to continue this. I think one of the tweaks that we've really worked on is anytime you're asking someone to do something for you, you have to figure out what you can do for them. So as you can imagine, some of our clients who are coming in for services on the crisis unit can be combative, anxious, angry, all of those and more. So what we've done is we've made ourselves available to the crisis unit staff as a team down here to go up and address the concerns, address the issues, to kind of take some of the burden away from them. We're used to working with this client population, so we go up, we address those issues, we answer the questions that maybe they don't have the answers to. So we take that initial blunt of the client's, anger sometimes, and that way we're getting that face-to-face contact with them too. They see us as an advocate for them. Someone can answer the questions, someone who's a go-to, but also the nursing staff, the techs, all the staff up there also sees we're not just asking you to help our clients. We're going to come up and we're going to help you too. So I think that's part of what really made a buy-in for especially the crisis unit staff.
That is really fantastic. And what a positive secondary gain from doing a QI project, just this feeling of being in it together and that camaraderie that will certainly translate to future projects, whether it's with their metrics or with your metrics altogether. That's fabulous.
So great work. I mean, we've been following you along with this for a while now, and it's really nice to see that positive result that you guys have. So what else can you look at in terms of retention, or where you can work on retention? Because when I think of your project, that's right in the name, the retention project. And so retention isn't just the first appointment. So tell us a little bit about what else you have going on with retention. And, you know, the importance of that is if you have them in treatment, better things happen, fewer bad things happen. So give us some more thoughts about kind of where you are with retaining folks at other points in the treatment continuum.
Yeah, this is something Tina's very, very good at executing and reminding us to do is if a client is say they miss a week and they're not the type of client, or if anybody misses really, we make it a point to reach out to them, make it a point to make contact with them if we can to see if they're okay, for one, to see what the issue is and why they didn't return, just to kind of get that feedback to see if there's anything that we did that we can do better. And also, you know, just essentially just showing them, kind of like Tina said, that we are advocating for them and advocating for their recovery, mental health, et cetera. And we want them to succeed as much as they want themselves to succeed. So we just want them to know that we're in this with them and they're not alone. So we like to give the message to our clients that, you know, we're here to help them. Like, we're here to catch them. We're not here to catch them, if that makes sense. And that was told to me by that was a Jeremy Sagan quote that I'll never forget, because I thought it was very profound, because he was we were talking about this specifically about, like, how do we keep clients engaged? How do we do this? How do we do this? And, you know, a lot of people in the MAT program, you know, they're afraid that if they admit that they're doing this or this, that we are going to ultimately discharge them or let them go from our program. But that's not how our program's founded. That's not what we're based upon. We're based upon honesty and core values. So we essentially try to implement the fact that if you tell us what the problem is, we can help you fix it. It's just a matter of you telling us what it is and instilling that message. So in that regard, that's proven very, very beneficial as well, just to keep the continuity of care going. Have we seen clients kind of fall off the map, for lack of a better term? Yes, we have. But you'll see that with anything really. But the mere fact that we have progressed the way that we have and we've retained the amount of clients that we have is we're over. Megan, you'll be happy to hear this. Is she still in here? I don't see her. No, she left. But yeah, we're over the 100 mark. Meg will be happy about it. Sheena will be happy about it. So we're over the 100 mark now. And that's
awesome.
Oh, thank you. Yeah, but it fluctuates, you know, as any program does. And I think our projections were our projections were at right around 107 this time next year, and we're very, very close to that, right? I think we're at 102 today. So to answer your question, Dr. Howe, a lot of just communication from the change team to the clients directly to see if there's anything that we could have done better, if there is anything that we could change to make them potentially come back to us, or if they're just to identify what barriers are there for them, so maybe we can help them overcome those barriers to get to treatment.
Any sense about what the rate is that you have for people staying in treatment for the first 30 days, the first 90 days?
I do not have that data available, but I don't even really want to take an educated guess on that because I'm not entirely sure. But
by the way, that's a great answer.
Oh, okay, good. Okay.
If you don't know and you don't want to guess, don't guess.
Yeah, I'm not gonna. I won't guess.
Because that to me would be something worthwhile looking at now. If you think about it from two perspectives, one is just the treatment, caring for human being perspective. You guys have put a lot into getting people to get into the program and to stay and engage. All right. And you know that they have better outcome if they do. So once you've done all this intervention, how well does the rest of the stuff that you do with them in the treatment program sustain them in the program? And what is that rate? That's good because, again, if they stay in the program, better things happen. Yes. But just in addition to that, from a business perspective, if you look at this, if you spend a lot of time and effort because of that revolving door and that cycling, it eventually takes away from the services that you provide to the people who do stay in the program, because it takes so much time, effort, and so forth to kind of re-engage and keep that going, that it can lead to a lot of burnout. So to me, the next natural question for a QI project is, all right, what's the next step in retention there? All right. And you already described some things that you guys do. And so you need to look at the numbers and get a sense of where you're at, and has that changed over time? And is there room for improvement there? The other question I wanted to ask, or to have you guys think about, and this is because of problems that we ran into, is to identify what it is that you guys have done to not only be able to sustain the program that you had, but to continue to grow it over time. So there's no trail off to this. And so identifying what you guys think the key elements were from a process standpoint that you guys implemented in this, to not only keep it going and not regress back to the mean, but to grow it. That's an important lesson for you guys to take with anything else that you do going forward, because you learn from that. You know, that, wow, this not only works, but we can sustain it. Because the hardest thing is sustaining change, whether you're an organization or a client. So I would look at those two aspects with what you're thinking about doing.
Yeah, absolutely. I know it's very, very difficult to get there, and it's twice as difficult to sustain it. So that's one of the things that we always have to try to remind ourselves. It's like, yeah, we have gotten here. That's great, but how do we keep it there? How do we keep it growing from there? And you know, between the people in our change team, we're always trying to figure out ways to improve our program, to grow our program. Tina in particular, she's the head of the substance abuse department down here. She pretty much oversees everything down here, and just kind of really has done a good job with, you know, client interaction, keeping clients engaged in treatment, and it extends beyond her into the rest of the team as well. Her and I work very closely alongside each other, and I do not believe I would have been able to do what I've done here without her and the rest of the team's support and help. And Jeremy Sagan's not on here, but I'll give him a shout out too. But yeah, so without all of our pieces in place, all of our, you know, our chess pieces, we wouldn't have been able to make this project happen, let alone sustain it.
I mean, I was going to say real quick, that's really important. And as you continue to grow the program, you're going to face continuing new challenges as the program gets bigger. And so keeping your eye on that and trying to figure out what are the new challenges we face as we get bigger as a program, we have more people, we have more responsibility, And, you know, because if you just stay the same, then you're going to end up having problems. So you've done it, you've grown it. Now you got to keep your eye moving forward for how you're going to kind of learn from that to maintain it as you grow and face new challenges. Sorry, I cut somebody off there. I apologize.
That's fine. One of the things that from my perspective that I think we've been doing a good job is we're retaining staff.
Yes.
Okay. Now, why is that important? Because the clients need consistency. The clients need to see that when they come back, if they leave and they come back, they see the familiar faces. They don't have to learn everything all over again. You know, when the staffing consistency stays and maintains, then so many of my problems go away because I'm not constantly training somebody, constantly looking to see, you know, do they fit in with our concept of what we have going on here? You know, we have a concept of grace here, not punitive, you know, damages from choices that they've made. Just today, being Monday, we've had 3 clients return to us that have struggled in our program, left our program, but got to a place where they knew they were in trouble and they came back today. that's the success that I measure in a program, is how many clients return when things get really tough. And so, you know, that for me makes everything that we do worthwhile. And so that's what I'm working on, is retention, not only of staff, but when clients have a problem, we want to be the first one that they come to.
Yeah, that sounds like a really interesting number to capture. Is somebody may fall out of the program, but also capture how many of those people come back into the program, because that is a good sign. And so you can look at both of those aspects there, because, you know, to a certain degree, I mean, you never want to expect it, but you know you're going to lose a certain number of patients who are engaged in substance use treatment, particularly for the first time. So having some sense of their willingness to come back and engage with you guys because you do it well, and you do have that caring grace component to it, rather than, you know, and that's obvious from interacting with you guys.
Yeah, we're looking at things like, how can we implement maybe some contingency management for clients who have been here, you know, for 6 months, for a year. I don't know the answers to that, because we're using some other programs like Trust that uses contingency management that a lot of our clients go through. So, you know, that's one of the things we're going to sort through this year, is what can we use in that regard to keep clients, you know, here, to keep them engaged. One of the things I also think we do well is we talk to the clients and we listen. You know, Josh can tell you, if I say it one time a week, I say it 100, you know, hierarchy of needs. Are we meeting their needs? Are we helping them understand what needs are, and what can we do to fill the needs of the client? If we successfully do that, we keep clients engaged in treatment. And so that's basically the bottom line of my philosophy of care down here, is, are we meeting their needs? Are we meeting them well? And what do we need to do? Not necessarily them, but what do we need to do down here to change our program to meet their needs?
Yeah, meeting them where they're at. Yeah.
Any other comments? I know, Tina, you mentioned contingency management, and that was one of the specific questions on the form about getting some more information about contingency management. Would anybody from the team like to give a little bit more info on that, and how it's been implemented, or we're thinking of doing it, something like that, to give them a little something to go on?
Yeah, Tina, we have a couple of folks on here from our contingency management team that can talk about that. And I'll say we've not tried that from an introductory standpoint. I'm trying to think, did we ever throw that out as an option for our orientation group? I'm looking at you guys. Was that ever something that we considered? We currently use it with our highest level of care group for folks that we are trying to retain in treatment after they've consistently struggled, but we've not tried it. I don't think we even suggested it from the get-go. I'm looking at Chena. Was that ever something we suggested?
No, I mean, I think maybe like it was one of our ideas somewhere, but not,
Yeah.
we haven't tried that at all.
Yeah.
We do it in the beginner group with pregnancy code.
That's right.
But not in our orientation group where we're working on retention.
Yeah, so we've been doing contingency management with our higher level of care group since last, if I say April, does that sound right?
I think so.
COVID has destroyed the calendar of my brain since last April.
Is this April?
I don't even know. It feels
wish.
like it right now, but
I wish. And we have seen positive results with, so we were measuring a couple things with that. It has helped increase retention with appointments overall. It's helped increase show rates with individual therapy, and it's helped increase rates of negative drug screens. So across the board, we've seen positive results for that.
So
But it's a-
essentially, you can use contingency management for anything within the program that you want to use that you think that the clients need a little extra help with motivation on, in a sense, because they may know what they need to do or they want to do, but they can't quite get it implemented. And so contingency management is really built around positive reinforcement to increase the frequency of a behavior. It's most often used and talked about within the context of stimulant use disorder because we don't have medication to kill the cravings for that. And so, but the principles work for everything. Doesn't matter, what you apply it to within substance use treatment. You can use it to bump up the motivation. In one case, we were doing it to increase show rates for individual psychotherapy appointments. And we didn't want to struggle with that. And they knew it helped, but just getting them there and getting it going where they could on their own then realize the positive benefit of that. That's what it's all about. It's not a long-term thing that you do, but it's helping people get over the hump so that they get the positive reinforcement out of the program from the games just to get them going and do that. So you can apply it to anything, basic treatment, long-term treatment, very specific behaviors that they're struggling with. So we're happy to talk with you about that if you want some ideas.
Yeah, it seems to be working very well in our trust program. That's what we're using contingency management in right now. And that's the only contingency management we're using because several of our clients are going through the trust program.
What is the trust program, if I could?
Yeah, it is a program. It's a 12-week program. It was made by the people who developed the matrix model. It is a 12-week individual and group participation, and it is for stimulant use disorder. It's an entire curriculum that was developed specifically for that. Our clients are really, really engaged. We have one group that's going right now. It stays consistently at 10 or 11 people. So we're looking at probably sometime this year, starting a second group so that we can meet the needs of our clients. We're really liking the program, and we started it last year. What about 6-7 months? No, about almost 8 or 9 months ago now.
9 months ago, yeah. Mm-hmm.
And
I'm quickly taking notes for this for our program. Is the programming is a curriculum called Trust?
Yes, and we can get you the contact information and all that and send it to you.
That would be great.
Yeah, we went through, there were 4 of us that initially went through a training, and then now we are trainers for our staff. And so we can train our staff to do it. It consists of 12 individual coaching sessions and 12 weeks of group. And we give them, the behavior we chose were urine screens that were negative for stimulants. Sure. And so they can give us a urine screen that is negative for stimulants. They get a $10 gift card. So they get 7 of those gift cards during the 12-week process because of the $75 cap that Medicaid has.
Sure.
Give them $5 gift card just for coming to the orientation and getting started in the trust program.
Okay.
Perfect.
That's great. Oh, thanks for telling us about that.
Absolutely. And a lot of our MAT clients, they go through our first step IOP and then they transition into trust because they're also using stimulants.
Yes.
Sure.
So it gets them engaged longer.
Mm-hmm.
Yeah.
Also meets, that need of their stimulant use disorder.
Yeah. Oh gosh,
Like
that's great
Dr.
retention work.
And like Dr. Hout said, there's no medication specifically designed for stimulant use disorder. So I mean, this is what we have, and it's proven effective so far. And we have a lot of clients just being in the tri-state area, especially where we are in the Northern Panhandle, that are treatment in lieu from Ohio. So a lot of those clients are required to be with us for, what is it, a year? I believe. Yeah. So they'll go through our IOP programming, possibly coupled with our MAT programming, into trust programming, which is another 12 weeks, into relapse prevention group, which lasts in perpetuity. So we have the ability to allow them to continue with services through a multitude of facets with us for that whole entire year, even if they're court mandated. Perfect case scenarios, they continue with the treatment after their mandate is up. Doesn't always happen, but we have those options available, and it's just, yeah, like with, sorry, yeah, the trust program, it's absolutely excellent.
Is
I believe we were one of the first, if not the first people to implement it in the entire state.
yes, we were in the first training, and then we were the first actually to get a group going and to keep it going in West Virginia.
Fantastic
Yeah.
work.
First graduate.
In the nation, actually, that actually have a program like this going.
You just use people who have DOC of stimulant, or is it people that just use stimulants?
You can do it either way. We've allowed people who have just a stimulant use diagnosis to be part of the program. So it doesn't necessarily have to be their drug of choice. A lot of times opiates is the drug of choice, and then stimulants are coupled with that very closely. So we'll allow just the diagnosis of stimulant use disorder.
Tina, if you could send me that information, I'll get it out to the group if you don't mind.
We will do that.
Sounds like you might be training some people outside of Northwood potentially as
I
well.
was going to talk about some sort of deal we can make there.
It's a great
cash or money order.
You actually get a $5 gift card for coming to the first thing, and then we'll see how it goes. Yeah.
There we go.
Dr. Jackson, you had unmuted earlier, I think before we started talking about trust. Did you have another question or anything like that? I saw you unmute.
No, I have a lot of trouble. I have a lot of trouble being able to implement contingency management in my population. I don't know how much of it is due to it being rural and how much of it is due to being courage. Some things we thought about is just using it more in our outlying areas and not specifically at our main center in Buchanan. Other things we thought about is using it primarily just for disadvantaged homeless populations, where we just give them work a lot with United Way in Clarksburg. So providing people with transportation vouchers of some kind, as opposed to just strictly monetary rewards. Other ideas we'd had was trying to figure out, because transportation is a huge issue for me as well. Those were the things that I was going to say, but I haven't really had much success being able to implement anything thus far.
We're happy to try to help you with that going forward if you'd like. I mean, it sounds like a really good idea. One of the key things we talk about is finding reinforcers that are meaningful to the people that you're working with. If transportation is a huge barrier for their life, man, they'll work for that.
Yeah, we have some transportation stuff with WVU currently in our group in Clay County. And then I think we're trying to work with sort of partnering with St. Joe's and WVU to have something sort of Buchanan or Upshur County specifically that we're working on right now. Obviously, we all know what great success mode of care always is. But we try to encourage our patients to fill out reimbursement forms. Mostly that's the thing we have most success with. But I'm trying to figure out if I could do contingency management for transportation as well. It's an idea that I thought was really valuable that someone gave me, but that might be more specific to how geographically spread out my population is. And that's a big hurdle that I have.
We have been working with lots of sites on contingency management, and one of our sites that we just had a meeting with last week. One of their ideas they are going to work on. They work a lot with the homeless population, and so they're thinking about doing transportation vouchers for a lot of their incentives. But then they're like, we have just a few patients that wouldn't like that they don't have transportation as an issue. And so they were like, they wouldn't appreciate that. So talking about just what is most useful and beneficial to the patients of your clients. So, but I definitely think that transportation is something that you can use contingency management for.
I feel like for my population, using it to encourage people to come to individual therapy might actually be a better thing than using it for UDS results, because I just can't, all of my patients talk to each other. They all know each other very well. So the idea that I don't know, I can't wrap my head around how to to do it for UDS results in a way that wouldn't just be paying people to be criminal as opposed to
Or be punitive.
Yeah, it would be a challenge.
Because
I haven't figured it out.
It can end up being punitive. And so, one of the things I always think about with reinforcement is that whatever it is that you're assigning to this is clearly a reinforcer. But you want to think about the other behaviors that you end up reinforcing. All right. So let's say, you give them a transportation voucher and they're going to use it for X. You want to make sure that whatever that X is, in addition to the transportation, has additional reinforcing values to do that. So if you give me a free ticket on an airline, that's a transportation voucher, because I waited in line for, X amount of time to cancel my flight, but it's a pain in the ass for me to cash that thing in. You've given me nothing, so I'm not going to use it. I don't care. It wasn't reinforcing. Or if you say I have to go do this with it, then I'm going to be like, I don't want to go do that. That's not reinforcing for me. So making sure that you can link it up in a way so that not only you're doing something for them, but that actual thing is reinforcing immediately and then thereafter. And so therapy, sometimes it can be painful immediately, but usually you get good positive reinforcement out of an individual therapy experience and you feel better about it. You feel more supported. You get all those kind of extra levels of reinforcement that are positive, that increase the chances of those behaviors happening. When you tie it to a urine drug screen, it gets really complicated, which is why you're having trouble getting your head around it, because it can end up feeling punishing or being punishing. And so, yeah, we struggled with that and we threw it out. We stopped doing the reinforcement for positive or negative UDS.
I think when I first arrived at my location, I don't know how much I should say, but I think our contingency management grant dollars were specifically tied to just stimulant use disorder, and I couldn't figure out how to not be encouraging all of my patients to then use methamphetamine. That's my thing. Like, that's not great.
Yeah,
because they would all no, I'm sorry, that's just for people that use methamphetamine. All right, be back in 5 minutes.
Yeah, which tells you how hard people are looking to get positive reinforcement in their life. And the data.
But tying it to therapy, I think, is that I was typing it as we were having the exchange.
I mean, that's great, but there is good data that indicates that contingency management works with any substance use, whether it's in an opioid use program where you're using Suboxone, but they're struggling with other aspects or struggling with that. You can use it for that. You can use it for nicotine replacement. You can use it for stimulants. You can use it for alcohol, on and on and on and on and on.